where it says it's missing plaque. That's missing plaque. I thought like there was missing plaque.
Oh yeah.
Not he kept like meaning
like there was
they're
plaque
extra
there?
clean with no plaque.
Like, oh, you're missing
Yeah,
plaque
you're
with your
saying
toothbrush, or there's plaque missing from the toothbrush?
Yeah. So
You're missing plaque with your toothbrush.
yes, I thought it said he was
that's what I
missing.
get, but
Not
I
he
thought
was
other
like he
people
was.
were
It's
confused.
just missing plaque.
Missing plaque.
Like no
As in
plaque.
it was clean.
Do you remember when we, do you remember when we did this in class about right side, left side?
Yes.
Right? Which side was on the quiz?
Left.
That's what that was about.
Yeah.
So this is it, guys. I try to go through it on these PowerPoints because, like I said, I'm inheriting a class that had an excess of slides of what you really need to know. Okay? So when I make your study guides, I really try to hone in on the core of what you need to know for the quizzes. But many times I'll see questions that I don't specifically see incorporated in a slide for you guys. So that's why I need you to really listen when I'm talking about one example or I say things like you may see it again. That's a really big clue because you probably will, because I saw it and I didn't see it specifically in a slide. So I'm talking about it. And I know you guys get tired after lunch and sometimes I can be really boring and I apologize for that. But we have such limited time. It's important with your study guide. I make a note on mine that you write down. I'll ask you questions. You go with your study guide. You look at your slides, okay? But that one specifically, that one was one we went over. And if you remember when I reviewed it in class, which side did I use?
I think right side.
Right side, yeah. So that's basically, because I didn't see that and I wanted to make sure you were aware with hygiene, because it's a really practical slide and it's something that you'll see a lot in clinic with your patients. They'll miss those areas depending on which hand, okay? All right, so yes.
For like groups that have HIV blocked, are we expected to get the lecture recorded if that's?
You are expected to get your study guide from someone, first of all, to let me know
Oh, okay.
that you're gone, and then to come to me, because I make plenty of copies of study guides, but I'm not going to hunt you all down and chase you down with a study guide. That's not my job, that's your job. You know we have a quiz, right? It's on the syllabus, it's just posted everywhere in class, right? We get emails about quizzes, time to download, so it's up to you to get with a buddy or get with me, and I'll give you a study guide. Okay, so anybody on HIV rotation, let me know. You can shoot me an email the day before, not a big deal. And then make it a point to come up to me and say, hey, do you have a study guide for me? And then get with a classmate, get those notes, okay? All right. Questions? Okay, we're all on fluorides. All right, so let's talk about fluorides. You guys have had already a lot of exposure. You've talked about different types of fluorides. We've had another review with all of our reps. When you pull out your study guide and you look at some of these questions, we're going to cover what material is going to be on the quiz and what you need to hone in on. We're going to learn about the major mechanism of action of fluoride and decay prevention, the history of fluoride, how we came to find out how effective it was, how important it is in different roles, whether it's in decay risk, in water fluoridation. How do we know when we see fluoride toxicity? How do we recognize symptoms? And how do we manage fluoride safely so our patients can get the benefit and we protect them from toxicity? So let's talk a little bit about the history of fluoride. We know in the late 1800s, we started to notice a correlation between stained, mottled, brown and white spotted teeth and resistance to decay. And we weren't really sure what happened, but we knew that, especially in the United States, and specifically the southwestern part of the United States, a lot of people were having mottled brown stained teeth. In fact, it was nicknamed Colorado brown stain for the area and for the degree of staining present in the teeth of that population. Later on in the early 1900s, Dr. Frederick McKay studied the relationship between model teeth and fluoride in waters and wells, especially in Colorado Springs. And he noticed that that relationship showed a significant reduction in tooth decay. These teeth were ugly, but they were resistant to decay. So what was going on in this population that we could maybe take, extrapolate, perhaps minimize the stain and apply the benefits to the general population? Well, a chemist in the 30s, Churchill, reported that that mottled enamel and the substance associated, the cause of that was fluoride. The 40s, we started to conduct early research in different groups of people. Only this time we didn't throw in a lot like the wells were naturally occurring, and they weren't regulated or controlled. And we looked at two groups of people that got fluoride in their drinking water and people who did not. And what we found was that for a minimal cost, those who had received fluoridated water had a very significant reduction in tooth decay, 60%. So the public health department got together. Michigan was at the forefront, and Grand Rapids became the first city to start adding monitored amount of fluoride in their water supply, and hence to serve the millions of people that drank out of their tap and get the benefits. Since then, in the United States, fluoridation has grown. It's grown per state, it's grown per community, and we've seen the benefits of the reduction in tooth decay. And it's a significant reduction when we can eliminate one of the most common diseases in childhood, but also one of the most common diseases that affect adults. We learned a lot about caries. I know you guys are taking cariology now, and you're learning the nature of this disease, all the different factors that come into play, right? How you can manipulate certain factors and reduce the risk. Well, we know that it's infectious, it's transmissible, you can catch it, and if you don't get a handle on it, it can plague you from infancy into adulthood. So where does fluoride fit in with this? Water fluoridation, as discussed earlier, decreases that risk. When I was in school, that range, when we took boards, we had to know a range, 0.7 to 1.2. But in the decades after, what is the optimum amount? It's leaning now toward 0.7, right? Because we're also factoring other sources of fluoride. Do you guys know what fluoride is? What is it? Is it a chemical? Is it a chemical? I want you to know this because you're going to hear this from people that are anti-fluoridationists.
It's a
chemical. It's a chemical.
It's
It's a natural occurring what? Starts with an M. It's a mineral. Yeah, it's a mineral. Where is it found and stored in our body? Bones and teeth. Right. We see it also occurring in foods, in the soil, in our water. We have many sources. We know that we put it in chewing gum along with xylitol to reduce decay. We use it when we give patients hygiene instructions. We always add fluoride in one form or another in addition to dietary counseling. We talk about the pH in the oral environment. You guys are learning that probably in your caries class. So, what are conditions that would make a patient really need to have fluoride and some of the different forms of fluoride exposure? Ortho, right? Decreased salivary flow, poor dietary practices, a lot of our patients, secondary to periodontal problems, our perio maintenance patients, they come in with what? A lot of gum recession, right? So they have roots that are very prone to decay. And in what you've learned about teeth and decay, is the root more prone than the crown of the tooth to getting caries? Absolutely. Okay. So, indications for use. Sensitivity, Justin touched a bit on that. Xerostomia, those are two big ones. Patients that have many restorations and a history of decay. And we classify our patients into different risk categories. We have low, medium, and high risk. And we recommend fluoride supplements to those depending on their risk, those individuals. We definitely, all of us recommend a fluoride toothpaste, even to those that have what, low risk, right? Because that constant uptake of fluoride helps to prevent decay and make that enamel stronger. We have nutritional recommendations to reduce decay for children. We talk about baby bottles and what we put in there, and to eliminate sweetened substances, pacifiers, juice, encourage weaning, restrict when we give foods and snacks to children, right? And how often that we eat, right? All of this to reduce decay. So, what is the major mechanism of action of fluoride in caries prevention? What type of caries is fluoride the least effective against? It's the first question on our outline on our study guide. We're going to talk about slide number 14. Write it down. We know that the fluoride takes up what? Fluoride, or the tooth takes up fluoride through the what?
Dentinal tubules.
Through the dentinal tubules, through the enamel, through the saliva, right? The whole tooth can take it up once it's exposed. Fluoride brings something to the table that combines with enamel. What is that? When enamel takes in fluoride into the hydroxyapatite and it becomes fluorohydroxyapatite, what does that enable the enamel to do? Can it withstand an acid attack a lot longer than if it was just hydroxyapatite? That's the reason. And that's a really good point to understand, guys, because you're going to get parents many times that are afraid of fluorides. They hear things from friends. They hear things on the internet, on social media, about how fluoride can cause cancer and autoimmune disease and all sorts of problems. And they're going to want to know, well, if I brush and floss every day, my child won't get a cavity, and we don't need to do fluoride. And that's, granted, you raise your child in a perfect circumstance, right? But that's a long haul. When you imagine the reality of what? Of a child getting sick, throwing up, as they grow up, what do? They snack on sugar, they eat junk, they brush their teeth, or they don't brush their teeth. When is life perfect, right? By exposing that child from infancy to fluoride, the fluoride gets taken up and becomes fluorohydroxyapatite. And when life is less than perfect, guess what? Those teeth are more resistant, right? Because when we just talk about it theoretically, well, I'll brush and floss every day. That's an ideal way to look at it, but unfortunately, it's not reality. And that's why there's a dramatic decrease in decay in those children who were exposed to fluoridated drinking water, we looked at earlier, and those who were not, because it has a huge impact from development of the tooth all the way into adulthood. All of us benefit from that because it makes our teeth harder, stronger. Okay? at lower pH, the enamel won't demineralize. And so what I need you to highlight is the major mechanism of action of fluoride in caries is that it inhibits demineralization and enhances what? Remember that. And what type of caries is fluoride the least effective?
Root caries.
Nope. Because roots basically smooth surface.
Secondary caries.
Recurrent?
No. That's a good answer though. Nope.
White spot.
Nope, that's demineralized. What type? Smooth surface, root surface, recurrent decay, or occlusal decay? Which one? Occlusal. Occlusal. So remember that. You'll see it again. Which type of caries is fluoride the least effective against? And what is the mechanism of action? Inhibiting what? Demineralization and enhancing remineralization. That is the crux to all of the fluorides. Even stannous, sodium monofluorophosphate, the primary role of fluoride is to inhibit demineralization, okay? And promote remineralization. And we know, where is fluoride stored long term? Teeth and bones. Write it down.
Longest stored?
Where is fluoride stored long term? Teeth and bones. Because when we have excess, and we'll talk about this later, when people are exposed long term, as in many years, we'll look at the different levels of fluorosis, but we'll also see and talk about skeletal fluorosis. Have you guys ever heard of that? And that doesn't happen because you give them one in-office treatment or they got it from their community water fluoridation, which is monitored. It's usually unmonitored drinking water wells, and years. It's dose, duration, and time that's responsible for that. And the reason you see those deformities and staining like skeletal fluorosis and mottled severe fluorosis is because fluoride is stored where? Teeth and bones. So that's where you would see the results of long time unregulated fluoride exposure. Make sense? Okay. So let's talk about the benefits of water fluoridation. We talked about pre-eruption, post-eruption. We know how important fluoride is to the tooth. We look at different sources like water, supplements. There's foods that have naturally occurring fluoride. It's a mineral. It occurs in the soil. Yes.
Sorry, Ms. Lewis. Quick question. Did we go over what type of fluoride is added to the municipal waters?
Not yet.
Oh, no, yeah, all right.
Nope.
All right.
Nope.
Thank you.
Oh, no worries. Ask away, because this is for your benefits. I want you guys to do well, okay?
All right, thank you.
So we're going to talk about the, what type of fluoride is added to municipal? Okay. Okay, so we have different sources. We're not there yet, Christian.
Okay. We were talking about like water. Like,
Yeah.
So,
Yep.
Oh, maybe she
Nope,
said it.
because we're going to talk about how we get regulations. We have a public health department. Bless you. Our public health department is the Department of Health and Human Services, and under that we have the CDC that tracks disease, made up of epidemiologists, and they're oral epidemiologists that look at patterns in oral health and who benefits from what. And that's where we get a lot of our evidence-based science. What we recommend, they're going to back up because it's researched thoroughly. Fluoride is one of them. And then the Food and Drug Administration approves and gives a seal of how we use it. And we're going to talk a little bit about that. and we're going to talk about fluoride varnish. You guys, I know, are all varnishing in clinic. So we have these regulations in our government, and they guide what we put in our water. And it's usually each city, their council, they guide their municipal water department on whether to fluoridate or not. That's how it works. And so it's usually at city council meetings where you get people that are pro-fluoridation, anti-fluoridation, that come to try to sway our city council members on which way to vote, whether to fluoridate water or not. And interesting, they've brought lawsuits, but each time the Supreme Court has upheld the right to fluoridate over the logic of anti-fluoridationists. And why do you think that is? Because where do we get our evidence and research? Is fluoridating water evidence-based recommendation?
Yes.
Absolutely. So it's nonsense to give in to that. And so in most, well, all cases, they've lost. All right. And then we have the EPA that monitors extreme cases. The maximum allowable is 4 parts per million. We can see how much larger that is, and you can see why if people consuming more than this in their community water, if it's not regulated, and they're doing this for years at a time, have the exposures they do. Or they have children, they grow up, they live there, they get fluorosis. Does fluorosis affect adults? Let's say you were born and raised in one area of the nation and you moved to a place where you were drinking out of water, your water source was unregulated. Would you get fluorosis if your teeth were already developed?
No.
Could you, yes or no?
No.
No. It only, the primary are children during tooth development as it's taken in, because it's taken in pre-development and then the first 2 years after development, okay, of the teeth. Adult as well. So if your adult teeth are all in and you move to a place that has unregulated fluoride in the drinking water and it's high parts per million, you would not get fluorosis. But if you lived there for a long time, you could get skeletal fluorosis. It can affect your bones. Okay? But you're not going to see brown stain unless you were raised, born, or there from infancy. Okay? So we do have different governments that regulate that. And ultimately, the FDA tells us which products we can recommend in dentistry and for what purpose. And we're going to talk about that in regards to fluoride varnish. Okay, so we know that it's one of the top 10 public health achievements in the 20th century. Water fluoridation is, right along with immunizations and antibiotics, hand washing, seat belt regulations and laws. Those are all considered top public health achievements in our nation to keep us safer and reduce morbidity and mortality from different causes. So what I need you to remember and know is that it's a cost-effective way to reduce dental caries, and it can improve our oral health. Now, what you need to know for national boards and for this, I don't think it's on this exam, but I do want you to be familiar with this because you'll see it on your national board, is how do communities fluoridate water? What do they add? It's a powder. It's inexpensive. It's easy to use. They just pour it into the water supply. It's called sodium silicofluoride. It is the most commonly used component to fluoridate drinking water. Okay? That's why it's cost effective, easy to transport. And now the maximum optimum level is 0.7. 0.7. They give us a range. The range The optimum range is 0.7 to 1.2, but in the last several years, the maximum ideal amount is 0.7 parts per million. And the reason we have a range, 0.7 to 1.2, why do you think it's lower in warmer climates and higher in cooler climates? Why do you think that is?
People drink more water when it's hot.
Solubility.
Right?
Using more water.
Isn't it that?
It's exactly that. Because when we're warm, what do we do?
Drink more water.
Drink water.
Right. Even though, and that you can say may also be from the period I went to school where we were good at, 0.7, 1.2, even 1.0, that was okay. But in the last decade, you've seen 0.7 as really the critical optimal dose, okay? But yeah, because of that, when you drink more water, you get more fluoride. In cooler climates, we're not drinking water as much. So that's why we have the variation. But even if we were, you would still be safe because you're within that optimum range. So it protects you from fluorosis. Okay, so you guys understand what is the type of fluoride added to municipal water supplies? Sodium silicofluoride. So what are the benefits of water fluoridation? Write this down. It increases at greater overall oral health, right? For everybody?
Yes.
Can you repeat it?
What are the benefits of water fluoridation? Greater overall oral health. It affects adults and children, right? They all benefit from water fluoridation. They have a reduced risk because fluoride can protect adults also, right? Reduction of caries in children. And if we have lower rates also of root and crown decay in adults. And if we have all of these reductions in decay, what happens to dental treatment costs? Goes down. So what are the 4 things to remember? It's greater overall oral health, a lower decay rate in children, lower decay rate in adults, and as a result, what happens? Goes up or down? Goes down. So is it a win-win?
Yeah.
Does it help people who don't have access to dental care? Absolutely. Are you raising your hand or stretching? Okay. All right, so there's a lot of benefits to water fluoridation. All right. So it is the most effective way to reduce dental caries. Any questions on water fluoridation? And it's very cost effective. Look at that. 50 cents per person per year. By pouring in sodium silicofluoride into the water supply, they regulate it, they maintain it, and people get the benefits. Okay, so the next question, can skeletal fluorosis or severe fluorosis occur from community water fluoridation or from an in-office fluoride application? No. We're going to find out why. All right. We see some people, this is kind of neat, like bottled water. And is bottled water as regulated as tap water? What could you advise your patients?
Tap water.
What should they drink? Because a lot of people don't like to drink out of their tap. They think, oh, I don't know if I want to drink out of my tap. Or
Why
do
is
filters take out fluoride? You'll get that too. That's a common question.
Some water tastes better.
Bottled water is not regulated as well as tap. For not just fluoride, but I'll tell you this from a public health perspective, your health departments are on it, okay? Yeah, we do have exceptions to the rule, but they're exceptions, they're not the general norm, like Flint, Michigan. right? But that's an exception, and that's a gross exception, and the people responsible for that are looking at prison time in addition to financial costs because of the responsibility they have to the greater good and public health. So it's not just a financial liability, it also becomes a criminal liability for those who are involved in that. Because they're held to a higher standard and they have to regulate water. And so that's why a lot of these bottled companies, they don't have to go with all those regulations to bottle, even for the cleanliness part. And if you get imported exotic water, we know like $8 bottled water, whatever, they have even lower standards.
What?
Yeah. So you're, you know, what is it, Fiji or they come in glass bottles, they come in, I mean, you can pay 10 or 12 bucks at Whole Foods for water that you could get in your community free out of the tap and have protection. Yes.
Those big like glacier things, like where you go and fill up your big jugs, is that considered tap water, or is like, do you know if those are fluoridated or not?
That would depend on where their sourcing is and their well. And do they regulate their wells? See? And that's a fair question to call and ask. And those sources, usually there's a phone number or somebody there that frequents at different times of day to ask. But usually there's a website or a phone number for people, because sometimes they're unmanned and people just go and fill up. So yeah, that would be, it just depends on the source. So we can educate our patients that tap water is still the healthiest, cost-effective way to go. But the other question too is we talk about filters. People do reverse osmosis. People do different types of filter systems for their water. Do Brita filters remove fluoride? No. So if they have a Brita filter, yes. Drink your tap water, put it in your Brita filter, you're fine. Reverse osmosis, not so much. And there's even some types of water filtration now where they're selling it to people because of the pH thing, you know, this is alkaline water, or this is, a lot of those you have to be careful of because they can remove and the mineral content or control it dramatically to maintain a certain pH. Yes?
So Brita filters, is that similar to filters you use in your refrigerator?
Yeah, very similar. Yeah. The ones to look out for would be the reverse osmosis and the big filtration systems. Those are usually a few thousand to install.
Yeah.
And those are the ones that have the tendency to remove or reduce dramatically the amount of fluoride. So if you're getting it through your tap water and it's regulated and it's at a 0.7 or a 0.6, and let's say you do one of those, it could pretty much be gone. The benefit would be gone. So good to know, because you're going to get those questions from your patients. So that way you're aware. All right. So let's talk about this. Now this is a chart we're not going to see on the test, but it's a slide I want you guys, don't have to sit and memorize, but become familiar with it, because you will see this on national boards, especially on recommending fluoride supplements to young children. Depending on, again, where they live and the amount of water in their water, or the amount of fluoride in their water supply. From birth to 6 months, none. From 6 months to 3 years, if their water is got 0.3 or less fluoride, then they can supplement, and that would be the supplementation recommendation. If they're in the 0.3 to 0.6 range and they're under 3 years, that would be sufficient for them, okay? That child does not need to have a supplement. And if they're greater than 0.6, absolutely not. If they're older, 3 to 6 years, we can see how the supplementation would go up. Why do you think that is? Are baby teeth already done? Are they in the mouth? Are we already starting to see permanent teeth come in? Huh? Yeah. So we can see that potential for severe fluorosis will go down, but we're still guarded because teeth are developing. Okay? And we're looking at and basing recommendations on their main water source. I fluoridated my daughter. I did supplements with her because where I live in Hemet, we get our water up in Idlewild from Lake Hemet Municipal Water District, and they don't fluoridate. Not back when I had my daughter. And so I put her on polyvisol drops, which is a multivitamin, and the pediatrician asked me what was in my water. We had no fluoride. So he added fluoride to her vitamin drops. And I gave her supplements till she was 15 months. And it works. And mom was crazy with toothpaste with her, but laid her down, did her teeth, made her spit it all out. But we don't have decay at 13. And, I wish I could say she was perfect. She's not. She loves sweetened drinks and soda and loves junk at birthdays and Christmas and is a normal 13-year-old. But knock on wood, those teeth are solid. Really, really solid. So it does make a difference. And you should advise your patients to look at their water supply. Yes?
It's nice. I'm happy to get the chance to know this, but I bet there's so many parents that don't know this, like for their children when they are little, to do that, to seal them for later. It's a question for another day, but it's more like how do you encourage, how is this information being able to share out in the community? Like I know they do some community things, but like especially for moms and different things, that could be like if that was told, that could be a huge preventative.
Absolutely. You talk to your patients. You may not get their little tiny ones in the chair, but you get mom, right?
Yeah.
When you're talking to them, having a discussion, you get to meet and learn about your patients and their families. You can talk about that. This is a great slide to laminate. It's a good resource to have. You guys have the same thing in many different classes, I'm sure. But this is a great tool to use to guide patients. But they have to know where their water is coming from and if there's fluoride in their water and how much. And physicians and dentists, they go by that before they prescribe supplements first, is where is the primary water source coming from and is it fluoridated? And if so, how much? Because it can range from 0.3. Some communities say we fluoridate, but it's not the optimum. So that's where they need to know. Okay? Good question. All right, so let's go to the next slide. So, can skeletal fluorosis occur or severe fluorosis from regulated community water? Absolutely not. Remember that. Write it down. No skeletal fluorosis seen with water fluoridation, and we'll take it further. It's not seen if you give that child a fluoride varnish or apply a fluoride tray properly. Because fluorosis is dependent on what? Dose, duration, and time. Right? Now, if you overfill a fluoride tray on a little kid and they ingest it, that's toxicity, but that's not fluorosis. They throw up, you gave them a little too much. But that's not skeletal fluorosis and that's not severe dental fluorosis. Okay? Dose, time, and duration. All right. Gosh, we gotta move this along. All right, fluoride absorption. Okay. So have you guys seen fluorosis in clinic at all?
No.
No? Nothing? Not yet. You might see little white spots, and they're not from demineralization in young children. And that doesn't necessarily mean it's a horrible case. Those teeth will probably be solid. If they bother that patient or that that child when they're older, they can whiten their teeth. Many times the mild cases you can bleach out. So The severity of fluorosis, we just touched on it, depends on what three things? Dose, duration, and timing. And is fluorosis necessary consequence of preventing caries? If we're going to reduce your risk of decay, but you're going to have fluorosis. Is that true? No, it's not true. Just like we discussed, fluorosis can't occur once enamel is formed and complete, and the degree of fluorosis depends on their total dose over time. All right, let's take a look right here. We have different levels. Mild, this is what I was just talking about, very mild fluorosis all the way to moderate, and then we can see some of the more severe cases. In the severe cases, what's interesting is teeth gets really strong, then they start to break down the more severe and advanced the fluorosis becomes. And the reason we look at their water supply is we don't over supplement children with fluoride, from toothpaste, from supplements. Another thing to consider are some infant formulas can have fluoride. Some infant formulas, if the parent is using fluoridated water, is another rich source of fluoride. So those would be patients that you would not recommend supplementation to because they're already getting a steady dose. But we can see some of the different changes from normal to very mild to moderate, and then we can see how destructive some of the severe cases can be. Okay. So let's talk about fluoride toxicity. What are the symptoms? I need you to know this slide. What are the symptoms of fluoride toxicity? Throwing up. It's usually abdominal symptoms. They get cramps, pain, they feel nauseous, and when they're nauseous, what do we want them to do?
Throw up.
Get it out. Throw up.
Throw up.
The lethal dose, you need to know this, is 2.5 to 10 grams. You're going to see it again in an adult. I want you to know this range. It can happen quickly. The more severe it is, they can go into a coma and have cardiac arrest and be dead within 4 hours. So it's serious stuff. We take it. We use it carefully.
Has that ever happened in an office?
I've never had that experience, but it's clearly happened to be documented and to activate the emergency medical system. It usually happens to young children, and the most common that you see in the office are in offices that still use the foams and gels in trays. And if they're overfilled and that child or a young adult is sitting upright and it's running down their throat, there's a reason we tell you if you use those trays to position the patient forward so that excess will run out out, and to put the suction in there so it can be absorbed, sucked out, and not going down their throat, and to stay with your patient and watch them. When it happens in office, many times those trays are overfilled, first of all. That patient isn't leaning forward with the suction, and that clinician's not present. So they ingest it, and with little kids, those symptoms can happen as quickly as about 30 minutes. They'll start to feel sick, and you induce vomiting, let them throw up.
So you just like gag them?
You don't have to. They're gagging. They want to throw up. Yeah, I suggest you not gag your patient. But we can use other things, but we'll talk about that. Yeah, don't gag your patient.
I'll try.
All right, so what I need you guys also to understand for the quiz is certain lethal dose and safely tolerated dose. The range is from 2.5 to 10 grams on the lethal dose. CLD stands for certainly lethal dose. STD does not stand for sexually transmitted disease. It stands for safety tolerated dose, and it's the safe tolerated dose is a quarter of the certain lethal dose. So it would be between 1.25 and 2.5. Okay, it's only a quarter. So understand what these differences are. That CLD means certain lethal dose. STD is safe tolerated dose. And the safe tolerated dose is a quarter, 1/4 of the certain lethal dose. And for children, it's 1 gram. That is the lethal dose.
Wait, hold on.
1 gram. So slide 39, slide 40. Take a good look at those. All right. So what are some symptoms? What do we see when we see acute toxicity? I want you to be familiar with slide 41. Symptoms can happen within half an hour. They're usually abdominal symptoms. They get thirsty. They may drool. If they're really ingested a good amount, there may be more systemic results. So the first role is if they don't already have the urge, and in most cases they do, they just feel sick to their stomach and they want to throw up, we can use the syrup of Ipecac. Have you guys ever seen that or used it before? Yeah, it makes you throw up very quickly. So we want to make sure that we induce vomiting if they're not already throwing up. If they're just getting worse, call 911. Activate the emergency medical system. Get them help. Pretty clear? Does this happen often to this range? No. Do you guys even apply fluoride in trays anymore? What would we use now? It's a lot safer because people don't ingest it. Yes?
So this is basically the same thing as slide 39, except with excessive increased salivation and thirst.
Yeah, abdominal. They could have diarrhea, cramping, nauseous, throwing up, not pleasant. The more advanced, it becomes coma, convulsions, and ultimately cardiac arrest. Make sense? So if they're having abdominal issues, induce vomiting, and it'll usually end right there. 9 out of 10. That's it. Very, very rarely will you see this. I haven't seen this in private practice where you'd have to call the EMS, but we were always really careful when we gave fluoride too. And now we have varnish, so it's no longer such a big issue. Yes?
When my brother was a baby, the dentist had given him fluoride, and my mom noticed that he had increased salivation.
Mm-hmm.
So she went back to the dentist, and the dentist told her she didn't know what she was talking about.
Oh no.
And so she stopped it on her own, and then she stopped going to the dentist because she's like, my baby's never salivated like that before.
Yeah.
And so that I didn't, just recognizing that's a acute, a sign of acute toxicity. It can happen very quickly, just a little bit.
Absolutely. So that's why I want you guys to be familiar with that, because you'll see it. Okay? See it again on a quiz at least. All right, so how do we manage fluoride? Very carefully. We regulate it when it's in our water. We dispense it to parents, and they need to make sure that they keep it out of the reach of children, okay? They can get toxicity from drinking their bubblegum flavored act. And in many cases, a lot of these emergencies where you're activating EMS and they're really, really sick is because of home poisoning. Not so much because you're sitting in the office giving their child a treatment. In most cases, it's because kids get into stuff like their toothpaste tastes good. It's fruit flavored, right? It has princesses on it. Who doesn't want to eat it? Right? It has Muppets, it has superheroes, it has everything. They come in grape and bubble gum and every delicious flavor to a child. They're going to want to drink it. And many times if they are swishing and they're too young and they don't have the spit reflex pretty solid yet, what happens? It inadvertently can be swallowed. So fluoride management is really important. All right, let's go into our next PowerPoint. All right, so what factors determine the use of in-office topical fluoride? Recession. And recession usually see where? In what group of people? Older adults. Yep. What other determinants are there? Do they have dry mouth? Do they have existing caries already? Are they able to clean their teeth pretty well? Dexterity? And how many teeth do they have left? Are they losing teeth from perio disease, losing teeth from decay? So what factors determine the use of topical fluorides in the office? Age. Write that down. Caries risk status. What are their risks? Like this slide here. Do they have a dry mouth? Are they able to keep their mouth clean? And number of teeth. Those are all factors that would determine whether we use a topical fluoride treatment on them. What are alternative factors that are not related to patients directly? What about insurance coverage? Some plans don't cover it. It's an extra $20, $25 for a fluoride treatment. We want to let them know before we do that. We could recommend it, but it's wise to inform your patient. So write that down. That's an alternative factor, insurance coverage. And what are the professional guidelines? Remember the chart? We were looking at who gets what fluoride, how often, what are their risk factors. You're learning that, I'm sure, in cardiology, right? How often do you recommend fluorides to them, give them a treatment? And their informed consent. Some patients don't want fluoride. So that's another alternative factor, is informed patient consent. All right. So we're going to go down some of this. We could see the different types of fluorides, how they can remineralize some of the small lesions. Those are one of the patient-centered factors or reasons why we apply fluoride. You guys don't use this anymore. Back when I graduated, we had all this stuff in trays to give to patients. We even had foams in different flavors. We could even apply stannous fluoride. All these things we use to apply. Now we have trays, and this goes back to page 1 of our study guide. What is the maximum amount of fluoride that should be dispensed in an in-office treatment? We talk about the trays. This is what they used to look like. We'd put fluoride in trays and put them in the mouth. Remember this. Slide 13, fluoride trays, 5 ml. That's the amount. Maximum dose for an adult in-office treatment. So all of these are examples of when we gave the tray fluoride. We're going to blast through a lot of these because you're not doing that anymore. We're on to varnish. What I want you to know about varnish. We have 2 case studies on the back page. In a patient that complains of dental hypersensitivity. I'm on case study number 2. During scaling, what could be used to reduce the sensitivity? Absolutely. Now, did you guys know that fluoride varnish is FDA approved only for treating sensitivity? It's not approved for caries reduction. Did you know that? When we do our fluoride treatments, every time in clinic, we're using it off-label. It's not labeled FDA approved for a fluoride treatment, so to speak, to decrease caries. It's approved to reduce hypersensitivity. So if you have a patient you're scaling away on, their teeth hurt, you can varnish the root. If there's a certain one little spot, they will love it if you make them comfortable that way. If you have a patient after their cleanings that tell you my teeth just ache and then it goes away, those are your patients that you can do a fluoride varnish, and you're using it as it's labeled and approved by the FDA. Because when we do it as a fluoride treatment to reduce caries, we're using it off-label. Remember that? That's a board question. They're going to ask you about fluoride varnish. But nobody in the United States sits and writes the FDA, oh, can you give me permission to use it off-label? Nobody does that. They know we all use it as a fluoride treatment, and it's wonderful, and it reduces people being toxic to fluoride and ingesting it. So giving it in office as a fluoride treatment, you're not breaking the law, because it's widely accepted and it's now the standard of care. But just kind of a neat little fact. And you will have to know that. The off-label use is what we use it for. Okay? So yeah, you get a patient with sensitivity. What product are you using? Varnish. Yes?
So when they're displaying some sensitivity, would you apply it before you continue scaling? Or
You
after?
could. You could. If they're during that in that one area, sure, why not? And you could apply it after if they complain of, pain afterwards because they're exposed roots. So let's look at the second case study. It's number 1. In a patient that complains of severe dry mouth, secondary, let's say, to cancer treatment, what type of fluoride would you recommend?
Varnish.
What type of fluoride? We could varnish them in office, but we could send them home with something like Prevident. A fluoride that has how many parts per million? 5,000. It's a high amount of fluoride. That's why it's affected, it's by prescription. And we could also, in that case, recommend trays. Have you guys ever worked with fluoride trays? Yeah. We could recommend that patient, because think about it, if they've had atrophy of their salivary glands from cancer treatment, they're not getting saliva anytime soon. Is this going to become a lifelong problem for that patient? Yes. Are they going to have that risk of decay for a long time? Absolutely. So getting them custom trays and having them use things like Prevident, showing them the small amount to put in it and wear it for a few minutes every day can make a dramatic difference in reducing their risk of decay. And what I wanted to spend some time with you is showing you this, where I've seen this on clinic. Have you guys used MI paste?
Yes.
How have you liked it? Huh? Have you guys used it?
I don't think I use it right. How do you use it?
We could also, with MI paste, guys, when you do custom trays, with MI paste, you can put it in trays. You can have them, I've also had my patients that have used it on a clean mouth before bed. If they like a drink of water, many of them do because they have a dry mouth, I have them take a drink of water first, then apply some MI paste on a toothbrush, brush it around everywhere, and spit out the excess and go to bed. And it leaves a fine film. And at night, when their mouths tend to really get dry, it's protective. Yes?
Dr. Jules said she said just put it on your finger, like pea size, and then put it on the teeth and don't even spit.
Well, if it's pea size, that's one thing, but if you're foaming it up everywhere, I wouldn't recommend that you have them swallow it. That's different. You can do that with Sensodyne, pea size on a sensitive root. But that's different from brushing it around. Yeah, but no, there's nothing wrong with that. You could do that too. But you could see that we've all these different products. And the way, do you guys know the way MI paste works with the calcium and the phosphorus ions? They work similarly to fluoride. The enamel takes up fluoride, it takes up enamel, it takes up phosphorus, and it makes that enamel, that hydroxyapatite, stronger. So that's why you can recommend MI paste to your patients that are decay prone or have dry mouth. They even make MI paste plus, and that's in combination with 1% fluoride. So they have the benefit of the fluoride and the MI paste, and it's just one product. They're not having to use a lot of different products. What is the one warning, though, about MI paste? Do you remember? What kind of milk allergy?
Casein.
It's the protein, it's casein.
Oh, that's right.
So if they're lactose intolerant,
It's okay.
yes, they can use it. But if they're allergic to the milk protein, and these patients know who they are, they'll tell you. That would be the only caveat to using MI paste.
I think someone died or something.
Yeah, because some of those allergies, depending on how strong they are, can cause anaphylaxis to that patient. So that's part of reviewing their medical history, talking to them, asking them, do you have a milk allergy? Sometimes that can be easily slipped through on a health history, but I would always ask, are you allergic to milk protein? And those patients, without a doubt, know who they are. All right, guys, we've covered it. Any questions on study guide on what we covered today? Pretty clear? I gave you a reference on fluoride. Little notes to keep in handy for when you review for national boards. Some of the same information that we've gone through. You guys are set. 10 to 3.
All right.
All right. You guys have class now?
Junior seminar.
Do you want a bathroom break? Want to
Yeah.
take a bathroom break? Okay.
Yeah.
All right.
Thank you so much. No problem. Okay, so I got maybe percent.
We need to go get a drink. We need to go get a drink. Yeah. Just get water.
There's no acceptance like.
Yeah. Oh, this pasta.
I think on clinic you can ask.
And then like I was like,
Yeah. Did you drive?
I just got, yeah, and then. Oh, so she said, did she say so many things? Because when she started talking about insurance, remember, I started talking about. Do you do that?
Yes.
It's like Donna Carter or something.
Yeah.
I think it might be have to get the filter so it's like it's
Yeah, knocked out
right. Okay. Did you get this?
Where can I get water? Getting my
I wanted to get
like right across the
You
street.
guys who were in HIV clinic last week, who was in HIV clinic last week, will you come to my office to get your toothbrushes? Because I have them.
I didn't get my Oral B. I mean, what is it? The Sonicare? I don't know. It never arrived. Yeah. Yeah, I give him a call. Yeah.
On Thursday or Monday, but it's usually
I might have
Thursday.
taken a picture.
But you have to ask me, because I like you guys to get it done right away. Okay, all right, you go, okay? You go first.
Alright, I'm gonna get some water.
They need, it's nice to be, but that's their responsibility. They need to come. Yep, I'm totally available for them. Thank you. So what's up? How you been?
Part, I got 0. For hand skating, 0. For example, all kind of stuff, 0. What are you gonna do? That was awesome. So I'm just
Oh my gosh, he's so
I want to see how small it is. Is that? Oh no no. I want to see how small is the actual cylinder.
you know, all like
Try one of these for sensor then.
just something that like stood out. It's like all this stuff.
This is good. Check how small it is.
But you do
Smaller than the truck.
You just sent you the 19 numbers, right?
Well, I just sent you that.
Well, the other thing, or, okay, I did a lot. Yes, I put
I mean, do you already think
I still want to get a light one.
I still am missing mine.
If you ordered ours.
One blue, 2 greens.
No, you only got one of each.
I don't think this is gonna come to that.
Oh, you're right.
I think it's me.
I wanted to go to Denver that order was 2 blues and 1 white.
Okay, yeah. I still have my green as a store. I should have rid of it.
It's just not, it's not on.
Yeah, that's what I wanted. I wanted to really use that. So then, I don't know, I think that probably would be the best option for it.
Understand all the rest of that was all this unbreakable. But what I always think is that I choose to.
I don't know. Well, since it's summertime, I feel like if they don't do that early. So I was thinking all the electricity.
Throw up.
And if they don't, so information.
I guess I might as well go get I'm gonna go get more water
Who
too.
wants to play games?
Are you gonna man scout with you? Is that a block?
It's a block of hearts.
Velveeta.
Who wants to play?
What is that?
We'll make teams. Like this half versus this half.
No, we're going home. I want to go home.
You have seminar right now, so you can't go anywhere.
Okay, Gabriel
I don't think she's coming. She's not really 2:55. Let's go.
Okay.
She's coming because she's gonna talk to us about Elisa.
What?
Is that happening today or is that another time?
Okay. It's just like a game, like, and you have to like, so like I just like, huh? It was in the lounge. I'm gonna take it back. Take it back. So I'm gonna do it. How many time zones are there in Florida?
I was like, sure.
He's not here.
I'm guessing Florida.
She was like, great.
And I was like,
What was the first aerial conflict to alter the course of a war?
Pearl Harbor, I don't know, sure.
The Battle of Britain.
Yeah, it seems like
You're shaking your head like that.
Wait, let me try to find the difference. These are hard. What is the largest island in the U.S. outside of Alaska and Hawaii?
Greenland.
Long Island.
What?
It said the United States.
Oh, I didn't hear that part.
Which apostle symbol is a bunch of keys?
Hello?
What?
Peter, the apostle Peter.
Oh,
Symbol is a bunch of keys.
Like a
These are hard. What two Republican presidents once worked as male models?
Kennedy.
He was a Democratic.
So what is it?
Gerald Ford and Ronald Reagan. He was a movie star. Yeah, Ronald Reagan was a movie star. These are hard questions. I mean, it's an old game though, so they're probably a little dated. Okay, this is good. What country is home to the most Canadian geese from November to March? These are hard questions. Don't put it back. You guys don't want to play anymore. You guys play on your phone.
You know, I know. My
I think we just have to focus just information.
Yes,
So was it
it's
whoever
banned,
was
but I
in
think it's more
HIV
just like
clinic last week?
You guys go get your 2 questions.
Oh, yeah.
I did but I am like
I wasn't sure if you remember. No, I did. That I sent an email as soon as I let you know. Okay, yeah. I brought you more just in case.
I didn't trip her.
No worries. Yep. So now we should start. And she's the
But. Oh.
I want to do this to AJ when he gets out of
Doing like 5 hours.
That's initial of the I will make what? Oh, what about
These are the old ones. I can hold on to them, but I can put them here.
Yeah.
Oh, I get. Let's go. Yeah.
That's someone's birthday?
Oh, yeah, this
Birthday to you. Happy birthday to